So good morning, everyone. Welcome to Mechanical Ventilation Lecture. I don't know if this is a course that you're fearing. Sometimes previous students can make it seem daunting. It's like, oh, this is the worst course ever. And when you hear stuff like that, you think the worst. My advice is if you're learning a little bit at a time, it's not bad at all. But you have to stay up with learning the concepts. So if you think, oh, I don't understand this, maybe next week, no, you've got to learn the concepts as they are presented because the concepts build on themselves. So I need you to be learning as we're going, not just studying right before the exam. And if you do that, it's not bad at all. There's a lot of math in the course, but it's a matter of just plugging numbers into a formula. So it's not difficult math. It's just knowing how to remember the formula and when to plug into it. All right, so the course syllabus, this is a 3-credit lecture course. My contact information is on the course syllabus. You have my cell phone number, my office number, my email address. It says call to schedule an office appointment. You don't have to call. You can send me an email or a text if you want to meet with me. These are all of the topics that we will go through during the semester. And then as far as course materials, I don't know. If I hold it up, can you see it from where you are?
Yeah, we can see it.
Yeah, okay. So the OAKS ventilator management is a condensed version of the topics and the types of patients you put on ventilators. So it's a really good resource to have. Yes, yeah, if you have the brown version, that's okay too. And then the Egan's Fundamentals of Respiratory Care. Hopefully you kept it from last semester and you can reference it. So we don't use it a lot in this course, but during the second part of the semester, yes, it goes into a lot of physiology when you put somebody on a ventilator. And then the Mechanical Ventilation textbook by David Shellady. The information is spread throughout the book. So what I did, let me show you. I'll have to step back. Is on the lecture schedule, I put in the page numbers where you'll find the information in the textbook. So if it says McVent, it's referring to David Shellady's Mechanical Ventilation textbook. So the numbers are all over the place. It's not like this week is chapter 1, next week is chapter 2. So you'll need the course syllabus to know what page numbers to reference.
I have a question.
Yes, go ahead.
Sorry for interrupting. But did Kim inform you about the book situation, like the shortage going on?
No, but I think somebody did. Yes. So what books are you unable to obtain?
Basically, they're all out at the bookstore and they're all on back order, and they have been for a while.
And they have been for a while?
Yeah.
Okay. That we'll be able to work around that. My next statement was going to be how over the many years, the students don't feel like the textbook helps. So I've tried so many different textbooks. What I recommend is after you've had about a month's worth of lectures, things start to make sense. And then when you're reading in the textbook, you begin to understand it better. But to use the textbook to understand it, students have really struggled over the years. So Not having it for the first few weeks, I don't think it's going to be a problem at all.
Okay, thank you.
You're welcome. So grading for this course, there's 5 exams. Only 4 of them count. So if you have to miss an exam, or if you take all 5 exams and the lowest score gets dropped. There are 5 online self-tests, and if you forget one, it's okay. 4, you only need to take 4 of them. You have to take the final exam. It is worth 100 points. And then there's an assignment that I'll give you after spring break, or maybe right before spring break. It's a ventilator assignment where when you're at the hospital with your clinic instructor, you let them know about the assignment. They take you to a patient's room that's on the ventilator, and you have to record the data on the ventilator. And you have to do this for different modes of ventilation. And then that's due April 7th.
Yvonne, I have a question really quick.
Yes.
For the online self-test, oh, never mind. I really should have just read that. It said 5 points each. Never mind. I was going to ask if they were 2 points again, but I'm so sorry.
It's okay.
Never mind.
You need a 75% to pass, and that's 323 points for the course. So it is doable. You guys are going to do great. We will be giving the exams on the computers again in the classroom. And if you want to bring your laptop, that's okay. The computers that we have here have been re-imaged. Everything is up to date with Windows 11. The Respondus lockdown browser is updated. So everything is updated, and hopefully we'll have no problems. Cheating is never okay. And then this is a list of all of our lectures and what we will be discussing. So this week and next week are just lectures. And then on the 20th, you take part of the exam. And on the 27th, you take part of the first exam. So feedback from students is that there was too much information on the exams, and they just felt like it was really overwhelming. So what I did for exam 1 is I broke it up, and we'll do it separately in 2 parts. So exam 1 will have certain information on it, and then 1A, and then 1B will have other information on it. And then your online self-tests, of course, when you click on assessments in D2L, it shows you when the online self-tests are due. The final exam is on April 21st. This is my teaching schedule, my office hours. And then the rest of this is the course objectives for the course. All right, do you have questions? Comments? Did you download the PowerPoint for this morning, or do you have it on your laptop or tablet so you can start taking notes? No?
I just did, so.
Which one is that? Is that in D2L?
Yeah, in D2L, click on Learning Modules.
Okay. Oh,
And then a huge list of all the modules show up. And then the first one is called Overview of Mechanical Ventilation.
got it.
And then you just click on the arrow next to the title and click download. And then it'll download it onto your computer so that you can print it or do what you want with it.
I noticed there was a lot of other like worksheets or Word documents under the learning modules. Do we need to print them as well, or just the PowerPoints? Like, I forget exactly what they were. I think one was something with math. I just like to print everything at once. So I was wondering if we should do that.
Yes, I think that's a great idea. And then that way you have it and you can work on it if you're not near your computer. Yeah, what I'm showing you right now is from the first module, and it has all of the different practice with the math calculations. We're going to learn about waveform monitoring on the ventilator. So you've got some samples of those. And then I've got an older workbook that I put the chapter in D2L. So you have it along with what questions to use and then the answers. And then the older videos are down here. So to my way. It doesn't hide. Huh. There we go. I got to it anyway. You have it on your house. Do you want the lights to stay on? Oh, okay. All right, so we'll get started on principles of mechanical ventilation. As far as mechanical ventilation and ventilating a patient with a machine, as a respiratory therapist is the only profession that receives a large amount of training in mechanical ventilation. For nursing, they get a couple days with the ventilator. That's it. So when you're at the hospital and you want to look around for somebody to help you with something on the ventilator, you've got your supervisor, your fellow respiratory therapists, but usually physicians don't know that much about ventilators. They know settings, they can look at some of the monitored parameters, and that's it. So you're it, and you need to become an expert at mechanical ventilation. You're working with people from all ages that are placed on ventilators. So a baby could be born prematurely, not breathing well enough on their own, and they're going to need a ventilator. So you've got premature babies, children on ventilators, and then adults on ventilators all the way through the end of life. So you have to become the expert with all of these different patient populations. All right, and then to write down some notes, and I can also put it in the chat so you can copy it down. Who needs a ventilator? Like, why does a patient end up having to be placed on a ventilator? And the answer to that is infants through adults that have respiratory failure. So what exactly is respiratory failure? So there's two components to it, and I'll write it down in the chat. One of them is the ability to get air in and out of the lungs, and we call that ventilation. The other part is oxygenation. You might be able to get the air in and out of your lungs, but you're unable to get in enough oxygen to keep your cells happy. So it's ventilation and oxygenation. So let me write that down in the chat. So I wrote respiratory failure is the inability to maintain ventilation, meaning that you're moving air in and out of your lungs, and or the inability to maintain adequate oxygenation. So there is two parts to why a patient ends up going on the ventilator. So when we place a patient on a ventilator, we're pushing air into the lungs. And that is not physiologically normal. When we breathe, remember that our diaphragm contracts, our rib cage goes out, we generate a negative pressure in our lungs, and that's the reason that air enters our lungs. So normal physiology, negative pressure pulls air into our lungs. Then a patient is not breathing well enough on their own, whether they've had damage to their brain, or they have some sort of a neuromuscular disease, and now they're no longer able to get air in and out of their lungs. How do we get the air in? The most common way is pushing it in. So pressure builds up when we push air into the lungs. So on the PowerPoint, it says spontaneous breaths are negative pressure. Machine delivered breaths are positive pressure. So to save somebody's life, we need to help them breathe. So we push the air into their lungs. The problem with that is having positive pressure in the lungs can also damage the lungs. So yes, we're trying to save somebody's life, but we have to be really careful, because if we're using a lot of pressure to push the air into their lungs, it damages the alveoli, the alveolar capillary membrane gets damaged, the conducting airways get overstretched. It's just not a healthy thing for the lungs to be put on a ventilator and we use positive pressure to deliver those breaths. So this picture is showing what I was just talking about, how with normal spontaneous breathing on the left, you see with inspiration, there's a negative pressure. So this red line goes below 0. So that shows you negative pressure. And then when the diaphragm relaxes, goes back to its dome-shaped position, the rib cage comes down, that generates a little bit of positive pressure in the lungs, and the air comes back out of the lungs. So a little bit of positive pressure on exhalation. And then when we're done exhaling, the pressure in the lungs is considered the alveolar pressure. PL stands for pleural pressure, and pleural pressure is always a lot more negative than the pressure in the alveoli. We talked about this last semester, how we have to have A lot of negative pressure in that pleural space. That's what pulls on the lung tissue and keeps the lungs expanded. So here it's showing PL for pleural pressure. It's a lot more negative than what we measure in the alveoli. All right, on this side, we have positive pressure ventilation, and we're pushing air into the lungs. And when we do, pressure builds up. What does that do to the pressure in the pleural space? It goes from being really negative to being like 0 at the end of inspiration. So it even changes the pleural pressures a little bit. All right, did we do everything? It says identify the pressures in the pleural space, which is abbreviated PL. And we did. We saw the pleural pressures with spontaneous breathing around -10 at peak inspiration. But when you have somebody on the ventilator and you're pushing air into their lungs, it's 0 at end of inspiration. Then it says identify the pressures in the alveoli. We did that as far as spontaneously negative on inspiration compared to positive pressure ventilation, and it's all positive pressure. Does that seem straightforward at this point? We went from negative pressure, which was normal, to positive pressure because we're trying to help somebody stay alive. Let's learn the abbreviations of different lung pressures. So pressure in the pleural space is abbreviated as PL. Pressure in the alveoli is abbreviated as P-A. Pressure at the mouth or the airway opening, if we're talking about an endotracheal tube that's in the patient, AWO, I guess that's airway opening. And pressure at the surface of the body would be atmospheric pressure, and that's abbreviated BS. BS for atmospheric pressure. Body surface, I guess, BS, body surface, is atmospheric pressure. All right, and then the different pressure gradients in the lungs. One of them that's commonly used is referring to the trans-airway pressure. Trans-airway pressure is the difference between the pressure at the mouth compared to the pressure in the alveolus. So when you compare those two pressures, it's called trans-airway pressure. And we're going to apply that to a formula coming up in a little bit. Another pressure gradient is transpulmonary pressure. This is the difference between the alveolar space and the pleural space. All right, so on the picture, we have letter A showing pressure in the atmosphere. And pressure in the alveoli, I guess, would be C. Pressure in the pleural space is letter D. What do we do with B and E? I don't have anything for B and E. So I've got nothing for those letters. A is the airway opening. C is the alveolus. D is the pleural pressure. Okay, let's apply your newly found knowledge. What pressure has to be the most negative to keep the lungs inflated so they don't collapse? You want to write it into the chat? What pressure has to be the most negative? Rachel, do you know? What else? What's in the pleural space? That's PL. PA is the alveolus. PL is in the pleural space. So that's outside of the lung tissue. The alveolus is inside the lung tissue. Yeah, so it would be the pleural space. Very good. Oh, okay. All right, very good, guys. What is the name of the pressure gradient between the mouth and the alveoli? Very good. Trans-airway pressure. So trans is like across. So trans-airway would be across the conducting airways. I'm trying to help you have a way of remembering the word trans-airway. So just think you're like flying through the conducting airways from the mouth to the alveoli. How is that? Give you a little picture in your mind. Is transalveolar the same thing? No. No, transalveolar would not be the same thing. What is the name of the pressure gradient between the alveoli and the pleural space? Very good. Transpulmonary. PTP. Right. So good. You got an A on your quiz. All right. So the next concept we're going to talk about is lung compliance. It's a very important topic to understand, apply. It's a major part of ventilating a patient. So very important to understand lung compliance. And what lung compliance is a measure of the stiffness of the lungs, or you could say it's how well the lungs are able to expand. So sometimes when you push air, a volume of air into a patient's lungs, you notice that not much pressure builds up. Maybe you'll get 15 centimeters water of pressure building up when you push the air into the lungs. The next patient, you put the same volume of air into their lungs and really high pressure builds up when you're trying to put the air into their lungs. So why would you have low pressure in this patient and really high pressure in that patient? So it has to do with a couple parameters, and that's what we're going to discuss now. But to use the term correctly, when you say the lungs are high, have high compliance, that means that they are easily inflated with very little pressure. High compliance, very compliant, very stretchy. Compliance as a vocabulary word usually means goes along with. You know, if a patient is compliant with their medication, they follow their medication. If somebody has a compliant personality, they just kind of go along with everything. So you can use that definition and it'll help you with understanding lung compliance. High lung compliance, very easy to ventilate, very stretchy. So easily inflated with very little pressure. That's high compliance. Low compliance indicates that the lungs are stiff and it takes high pressure to ventilate the lungs. So low compliance, the lungs are stiff, and we have to use a lot of pressure to push the volume of air into the patient's lungs. And we'll notice that a lot of pressure builds. 30, 35 centimeters of water, 40, which is really bad. So high pressure to ventilate somebody that has stiff lungs. What's another name for stiff lungs? High compliance or low compliance?
Low compliance.
Yes, very good. So stiff lungs, low compliance. And of course, we have a formula that shows some specific numbers for compliance. The general formula is the volume of air that you're putting into the lungs, and it's in mLs when we choose a volume for the patient. So that's what goes on the top of the equation. The bottom of the equation is the change in pressure as we're pushing that volume into the lungs. So it's volume over pressure. What's a good way for you to remember that volume goes on top, pressure goes on bottom?
What's that little triangle represent?
Change. The change in the volume would just be the, when the lungs were empty and then you fill up the lungs with the volume of air, that's considered the change in volume. And that's what the delta is for. For the pressure, it's the change in pressure. So we would find the baseline pressure and then find the pressure at the peak of the breath. And that would be the delta or the change in pressure. I'm going to explain it some more. All right, so here it says VT or tidal volume is the volume of air going into the patient's lungs. PIP. When a volume of air goes into the patient's lungs, you will note that the system pressure builds during inspiration to a peak and then drops back down to the baseline during exhalation. The highest pressure which is attained during inspiration is called the peak inspiratory pressure. That's the highest pressure. So as the air goes in and fills up the lungs, you'll see that the pressure just keeps building and building as the air is going in. And then inspiration ends, the exhalation valve opens, and now all the air comes back out again. So the peak inspiratory pressure is the highest pressure that built up during inspiration. So does that sound clear enough? Do you need anything reworded to help you understand, or you're good with that? So the pressure that builds when we put the air in is called the peak inspiratory pressure. And then of course, everything in respiratory, it's not good enough that it has a name. It's got to have 2 names or 3 names. Peak inspiratory pressure is also called peak airway pressure. And it means the same thing, just different ways of referring to the pressure that builds during inspiration. All right, so peak inspiratory pressure, PIP. You can never say that as a word. You always have to say the 3 letters. The PIP is. You never call it a word because it gets confusing. A lot of people look at that and they say, oh, that's PEEP. No, it's not. PEEP is PEEP. It gets very confusing if you're talking to another respiratory therapist. You're talking about the peak airway pressure and you're saying PEEP. It's going to confuse the heck out of them. They think that you're saying something different, PEEP. So you can never say PIP as a word. You always have to say the 3 letters, or you can say peak airway pressure. PIP, peak inspiratory pressure, peak airway pressure. Got it? All right, now to tell you about PEEP. PEEP stands for positive end expiratory pressure. And this is like the baseline pressure that stays in the lungs at all times. And we have a lot of information coming up on PEEP, but just for now. Just to give you a little bit of information about it, it's just a baseline pressure. Like you keep a little bit of a positive pressure in the patient's lungs all the time when they're on the ventilator. And we'll talk about why in a little bit. So when you're plugging into this compliance formula, the delta P would be the peak inspiratory pressure minus the PEEP. So you're looking for the change in pressure. Peak pressure minus PEEP is your delta P. I want to, whoops, trying to go backwards. So what would be the compliance if you plug these numbers in? Like the tidal volume you put into the patient's lungs was 400 ml. All right, so I just gave you some numbers. I want to know if you can correctly plug that into the formula. So on the top is where you're going to put your tidal volume. And then you have to figure out delta P. And the way you're going to figure that out is you're going to take the peak pressure and subtract the PEEP. And then you divide the top number by the bottom number. 16? Oh, 400 divided by 25. Did you do 30 minus 525 on the bottom? 400 minus 400 over 25? Yeah. And you get 16? Yeah. Okay. Yeah, I thought it was going to be 8 for some reason. No. Yeah. Okay. Got it. Yeah. So did everybody get 16?
Yes.
Okay. Okay. I was expecting you to put it in the chat, but if you do it correctly, you come up with 16. And then the units are mLs per centimeter of water, volume over pressure, volume in mLs, and the pressure is in centimeters of water. So the units are mLs per centimeter of water. All right, and then to tell you that there's 2 types of lung compliance. The first one is called dynamic compliance. It's a combination of things that contribute to the number. It's the stiffness of the alveoli and lung parenchyma and the airway resistance combined. So let's talk a little bit about airway resistance. It says that airway resistance is affected by the lumen of the airways. So if you are pushing air into a tube and it's really big, and you push the air through this really big tube, the molecules aren't hitting much. They can slide easily through, and you don't have much resistance. You don't have the molecules being hindered by the walls of this big lumen. So the air can flow through very easily. Now imagine trying to put air through a really small opening or lumen. Now, when you try to push the air through, it's a lot harder to get the air through because it's a smaller space, and that smaller space creates a lot of resistance to airflow. It kind of inhibits the airflow. Maybe that would be a good way to describe it. It inhibits airflow. As far as the understanding of the word resistance and air going through a large lumen or a large airway versus a small airway, do you understand the meaning of resistance? I need to hear from the student. Let's see. Whiz Bean, Happy New Year.
Hi, Happy New Year.
How are you?
I'm okay. How are you?
Good, thank you.
All right.
As far as resistance, can you explain to me what your understanding of resistance is?
Oh, okay. I think the airway resistance is about like when you're trying to push air inside of the airway, and then it's like you gotta apply more pressure, or there should be like stronger pressure to put it in, because there's some kind of I don't know how to really explain it. Like, I don't want to keep using the same word, but
I know it's hard to describe resistance other than using the word resistance, right?
yeah.
Rachel, what do you have to say?
I mean, you're using more pressure because there's something like blocking or obstructing the airway, and like the bronchial constriction, it's making it smaller. So you need more resistance to get through a smaller airway. You're saying more force.
So when there's a lot of resistance, you need more force to get past the resistance.
Yeah.
Okay.
Like if there's secretions in the airway, it's going to block part of the airway, so it's going to be harder to get air down.
Right. Yeah, so saying it's harder to move the air, what we're referring to is more resistance to moving the air. So if it's harder to move the air, there's just more resistance to moving the air. All right, very good. So how is airway resistance showing in patients on a ventilator? Well, the first one is a small endotracheal tube. So when you were selecting endotracheal tubes in your equipment lab and you had to intubate your mannequin, did you choose the really small size to make it easier to intubate, or did you choose a larger size? What size did you end up choosing?
I mean, you're telling us the average sizes for male.
I would say it was the size that lined up with the patient or what it should be for a male or female.
You want to use the largest one possible.
Which is large, yeah.
Yes, so the larger the tube that can fit comfortably through the vocal cords is the size tube that you want to use. In adults, it should be an 8.0 or an 8.5 in larger adults. Why not use a 7 or a 7.5? Because the smaller the tube, the more resistance to pushing the air through that tube. So somebody could have perfectly normal lungs and you intubate them with a size 7 tube and you connect them to the ventilator, you see the pressures are kind of high pushing the air into the lungs. Then you take that same person, intubate them with an 8.0 or an 8.5, and you notice a lot lower pressure when you're pushing the air into the lungs. So small endotracheal tubes offer a lot of airway resistance, and it causes a lot more pressure to build when you're pushing the air through it. So size 8.0 for adults is the standard tube that you're going to use in the hospitals when you're setting up for intubation. Now, it's possible that there's so much airway swelling that whoever is doing the intubation can't get that size 8 tube through all of that swollen tissue. They're going to ask for a smaller endotracheal tube. It might be a 7, sometimes with severe swelling, 6.5. So keep that in mind when you put the patient on the ventilator and you see these high ventilating pressures. The reason is because you had to use a small tube in order to get them intubated. All right, so small endotracheal tubes will increase airway resistance. In the conducting airways, we know the conducting airways are surrounded by smooth muscle. And that smooth muscle can constrict. And when it does, it narrows the lumen, the opening of the airway. Instead of being wide open, now it's a lot narrower. There's also a lot of swelling that goes along with bronchospasm. So you've got the airways tightening, you've got swelling, and now the conducting airway that was normally wide open is now a lot smaller. When you try to push air through that small lumen, you're going to have higher pressures. The next one is secretions in the airway. So as the mucosa in the airway produces mucus, and the mucus is not being propelled up to the larynx to be removed from the lungs, it accumulates. And when mucus accumulates, it plugs up the small airways. Now, when you're trying to get air past the secretions in the airway, you're going to get higher pressures on the ventilator. Also, airway resistance, a very fast flow of air into the lungs will also increase pressure and affect dynamic compliance. Okay, and then the bottom summarizes it and says, all of the above will cause an increased pressure when the volume is delivered to the lungs. So how does this go back to the formula? So let me tell you, when you have a big number on the bottom of that equation, you're going to end up with a smaller answer. So if you have a pressure of 50 centimeters of water, and you take the tidal volume, you divide it by 50, you're going to get a small number. So you'll have low compliance. A lot of pressure will give you a low compliance. Okay, and then it's that same general formula is what you use to figure out dynamic compliance. The tidal volume. You need to know the peak pressure and the baseline pressure, the peak. All right, here's a mini quiz. The first statement, is this true or false? Anything narrowing the airways or the endotracheal tube will cause an increase in pressure when volume is delivered to the lung. True? Very good, it is true. All right, the second one, is it true or false? Anything narrowing the airways or the endotracheal tube will cause an increase in dynamic compliance. True or false?
False.
Very good. All right. So it's actually the opposite, right? If we have narrowed airways, we're going to have high pressure. And when we plug that high pressure into the formula, we're going to get a low number. High pressure, low compliance. Got it? Okay, and now the last one, airway resistance is the only factor that contributes to dynamic compliance. Is it just airway resistance or is there something else? So is that true that airway resistance is the only factor for dynamic compliance? It's false. Very good. So not only does the dynamic compliance formula take into consideration airway resistance, it also takes into consideration how stiff the alveoli are. So stiffness of the alveoli plus airway resistance. It's those two factors that give you your dynamic compliance.
And what would make them stiff?
Pulmonary edema, ARDS, fibrotic lung disease. Yes. Okay. It's time for a break. So let's take a 15-minute break and then we will continue. I need to go downstairs and eat my oatmeal. I will pause the recording. Okay, so let's keep going. For dynamic compliance, I didn't give you the normal. Let me. Okay, here we go. For dynamic compliance, if you can add this to your notes. Normal value for dynamic compliance is between 30 and 40 mLs per centimeter of water. So if you plug into the formula and you come up with any number between 30 and 40, that's considered normal dynamic compliance. If the number is higher than that, then that's considered high compliance. And if it's lower than that, low compliance. Okay. The second type of compliance is probably the most applicable to patients on the ventilator. It's only looking at the stiffness of the alveoli and lung parenchyma. That's it. It's not looking at anything having to do with the airways or airway resistance. It's only a measurement of the stiffness of the alveoli. So how are we supposed to get this measurement? What we do is an inspiratory hold on the ventilator. Inspiratory hold. When you press that on the ventilator, it'll pause the breath there. So it'll wait for the lungs to be completely full at peak inspiration. And then the air flowing into the lungs is stopped. And you get a static measurement. And static means no air movement, just a static pressure reading. So when you stop the air from flowing into the lungs and you just do a breath hold or an inspiratory hold, you're seeing what the pressure is in the alveoli. So the inspiratory hold is going to give you a pressure reading, and it's going to reflect what the pressure is in the alveoli.
And this is done at peak inspiratory?
The newer ventilators, you press it and the ventilator will figure out when peak inspiration is. If it's an older ventilator, yes, you need to coordinate with peak inspiration.
Okay.
So you'll see the pressure building up and then you push the button. All right, so the formula for static compliance, it looks the same as that general formula I was telling you about, where you've got the tidal volume on the top and the pressure is on the bottom, volume over pressure. But this time when you plug in numbers, you're plugging in the pressure when you did the inspiratory hold. And that pressure is called plateau pressure.
How is it, is this different than peak inspiratory pressure?
Yes.
Okay. How is it different?
Peak inspiratory pressure is going to be a reflection of both airway resistance and the stiffness of the lungs.
Oh, okay, okay.
So it's going to be a higher pressure. Then when you do your inspiratory hold and you do a breath hold, now you're taking away airway resistance and you're only seeing the pressure it takes to keep that breath of air in the lungs. That will be a lower pressure because that pressure does not include any of the airway resistance. So like typically you might see pressure building up during inspiration of 30 centimeters of water. And then you press the inspiratory hold, the breath hold activates and you'll see 20 centimeters of water. So the plateau pressures will be lower than the peak inspiratory pressure.
Is there an abbreviation for plateau pressure?
No. No abbreviation. Okay, some more true or false mini quizzes. First one, anything narrowing the airways or the endotracheal tube will cause a decrease in the static compliance. Is that true or is that false? Taylor thinks false. Okay, why did you think that, Taylor?
I was thinking that because static was based off of the inspiratory hold that has nothing to do with the resistance in that. So that's why I think it would be false.
Positive, perfect. Good job.
Sweet.
Yeah, so static compliance has nothing to do with airway resistance. Airway resistance is taken out of that formula. You're only looking at how the pressure is in the alveoli. Okay, next one, fluid in the lung parenchyma or stiff alveoli will cause decreased lung compliance or decreased static compliance. So fluid in the alveoli, yes, that's correct. Fluid in the alveoli will make pressures higher when you're trying to ventilate. Stiff lungs take higher pressure to ventilate. When you plug in higher pressure into the formula, you're going to have a lower number. So yes, what you had to think in your mind is, okay, fluid or stiff alveoli, high pressure. Plug high pressure into the formula, low static compliance. Okay, so if you see lung compliance, I'm going to write that in the chat. Lung compliance, static compliance get used interchangeably. So we've introduced some terms here. We talked about dynamic compliance. We talked about static compliance. And now we're throwing in lung compliance. So lung compliance, static compliance, consider those one and the same. Dynamic compliance, because it's a combination of two things, it's not real helpful. So you don't see that formula used very much at the bedside. Plateau pressures and static compliance, yes. Dynamic compliance, not too much. I want to teach you about it. I want you to understand the different reasons that pressure builds when you're putting the air into the lungs. But as far as what you're doing at the bedside with formulas, it's static compliance, also called lung compliance. All right, the last one, an increase in plateau pressure will indicate a decrease in static compliance. Increase in plateau pressure will indicate a decrease in static compliance. Taylor says false, Christopher says true. Anybody else? Rachel says true. Yeah, so high pressure, low compliance. Okay. Yeah, so high pressure, low compliance. Increase in the plateau pressure, It's going to give you a lower static compliance. So it's true. That's okay, as long as it makes sense. All right, so now we're going to apply that information. We have a patient on a ventilator receiving a tidal volume of 500 mLs. You are at the ventilator and notice at the peak of inspiration, the airway pressure reads 35 centimeters of water. You record this value. You then stop the airflow for 1 second and notice the pressure reading. And you record this value. This pressure is also called the plateau pressure. It reads 28 centimeters of water. At the end of exhalation, you notice that the pressure does not go back to zero. Instead, there is a set positive pressure of 6 centimeters of water. This is called the peak. So that's our scenario. And we need to calculate dynamic compliance and static compliance using the values from the scenario. So I'll give you a couple minutes to do that, and then I'm going to call on people for the answer. Oops. There's the scenario. Yes. So calculate dynamic compliance and static compliance. Yes, keep a decimal point. Is everybody ready?
One more minute.
Okay. Okay, so Gretchen, for the static compliance, you're going to use the plateau pressure and subtract the PEEP. That'll give you the bottom number. So plateau pressure minus PEEP. Thomas, are you there? Thomas, can you help us out?
Yeah, I'm here, but yeah, I don't know how to do this. I'm trying to figure it out.
Oh, okay. Do you know what formula is for which one? Like, did you write down the formula?
Yeah, I wrote them both down. I'm just trying to plug them in now. That's like what I'm having a problem with.
All right, so what number did you plug in for the volume?
For dynamic,
No, like in the formula, what did you plug in for tidal volume? What is the top number?
500 mLs.
Okay, good. So that's a good start. Okay, now the numbers that you're going to plug into the bottom are going to change a little bit. So for dynamic compliance, what number should you put?
I don't know, is it 35 minus 28?
So 35 is the peak pressure. And then you subtract the baseline or the PEEP, which is 6.
So it's 35 minus 6?
Yes. So the peak pressure minus the PEEP, the end pressure. Beginning pressure, ending pressure. So 35 minus 6, what did you get?
29.
Yeah, very good. Okay, so now you've got the top number, the tidal volume, you got the bottom number, the change in pressure. So now you just use your calculator and divide those two numbers.
So it's 17.24
Yes, very good. And what are the units?
ml.
That's the top, yeah, and keep going.
So it's mLs and centimeters of water.
You got it. All right. Good job. All right, let's see who else can help us out here. Allison, can you help us with the static compliance?
So I came up with 22.7.
Okay, did everybody come up with 22.7 mLs per centimeter of water? Summer did, Rachel did. Okay. Brent, Danielle, Taylor. Denzil, okay. Is there anybody who didn't come up with? I forgot what we just said. 22.7 mLs per centimeter of water. Chris, what did you come up with?
I got the 22.7.
Okay, very good.
Yep.
You have a question? Go ahead.
It's not really related to this. You said the static has a lower, or the pleural pressure part has a lower pressure than the PIP, right? So is the normal value going to be the same for both of them still, or is it different? Because you give us normal value for dynamic, but not static.
Okay, yeah, I need to give you the normal for static compliance.
Yes.
Okay,
Sorry.
so let me give you the normal for static compliance. So normal for static compliance, 40 to 60 mLs per centimeter of water.
Same concept though, if it's lower, it's higher resistance. Or, yeah,
High compliance
high compliance. is better.
and low compliance, yes. So a number higher than 60 would be high compliance. A number lower than 40 would be low compliance.
I have a question really quick. It might be like, since our test is in a couple weeks, but for the mathematical questions that we do, are they going to be written out like a full scenario like this, or are you just going to be giving like the numbers how you did last time on the quizzes or on the tests in our last class?
Oh, I don't remember. I'm thinking it's just the numbers.
That's gonna be like a clear problem.
Okay. Yeah, I was just curious.
Yeah. And on the exam, when I give a bunch of numbers, I'm putting in numbers that you don't even need. I hope you guys know that by now. So if you're figuring out static compliance and I put in the blood pressure, you know you're not supposed to use the blood pressure, right?
Mm-hmm.
Okay, so just wanted to make sure of that.
Yes.
All right, so practice with this so that you can plug those numbers in and feel really comfortable with it. Remember to use units. And again, we go through this over and over again. All right, so this is showing one of the first graphics, and it's showing over here, it says pressure in centimeters of water. So when a ventilator breath goes into a patient's lungs, the ventilator keeps track of the amount of pressure that's building up, and then it shows it to you on a graph. So in green, you see the pressure is building up during inspiration. And when it hits the highest pressure, you notice that it drops. This is, I need to draw a normal. Let me see if I can draw a normal. Pressure, and this is time. So this has got a little something added to it, an inspiratory hold, but what does it look like if the inspiratory hold wasn't done? During inspiration, you would see the pressure going into the lungs is building up, and then the exhalation valve opens, inspiration ends, and now the air leaves the lungs, and you see pressure going back down. So that's a normal pressure graphic of a patient on a ventilator. Inspiration is the pressure climb to the peak. And then the exhalation valve opens, and then the air comes back out of the lungs. So pressure goes down and goes back to baseline. So that's normal.
I thought like a normal breath would have more of a inspiratory plateau before expiration.
So you're looking at patients on a pressure mode of ventilation, and that's why you're seeing that. Probably PRVC is being used a lot at the institution that you work.
Maybe, yeah.
Yeah. Yeah, so that's a pressure breath, and pressure builds up immediately at the very beginning.
But also on non-vented patients, isn't that the case? Like in normal breathing, if we're just a non-vented, like any one of us, like when we breathe, there's like before you get to peak inspiratory, it kind of levels off a little bit before falling back down again. It's not like a shark fin. Is that right or wrong?
Maybe you can draw it for me when you come for lab.
Okay.
I don't know if you're thinking of the V60 when patients are on BiPAP.
I'm saying if they're not on any ventilator support.
If they're not on any ventilator support, you won't see pressure building up. Inspiration is negative pressure.
Inspiration is negative pressure.
Yeah, the only time you'll see positive pressure is if you're pushing air into their lungs.
Oh, okay. Yeah, okay. Sorry.
Summer thinks maybe you're thinking of a capnography or the capnograph.
Yes.
Ah, good going, Summer.
Thanks, Summer.
Yeah, so you're looking at the amount of carbon dioxide coming out of the lungs.
Correct.
Now we know. All right, so on this graphic, it shows how pressure builds throughout inspiration. And then all of a sudden there's a drop in pressure and there's a pressure hold. So this graph is actually showing an inspiratory hold on every breath. And the inspiratory hold here, it's telling you, it's called the plateau pressure. And it's telling you what the reading is. It's 14 centimeters of water. Peak pressure, the total pressure that built during inspiration, peak pressure, peak inspiratory pressure, PIP, 28 centimeters of water. So why is there a difference between these two? And the answer has to do with airway resistance. If there's bronchospasm or a small endotube or secretions in the airway, patient biting on the endotube, you're going to see a bigger difference between the peak pressure and the plateau pressure. If you don't have much airway resistance, they're going to be really close together. A lot of airway resistance, they're going to be further apart.
Is the plateau pressure the same as the inspiratory hold?
Yes.
Okay.
All right, does that make sense? The peak pressure will be higher than the plateau pressure. The bigger the difference, the more airway resistance there is. So let's compare the second breath to the third breath. The second breath, the peak pressure is 28 and the plateau pressure is 14. It's the same though, isn't it? And then this one, the difference is 14, right? Here, what is the difference? 36 minus 22? It's the same.
14, yeah.
Yeah. So I guess they're trying to show you that this lung is stiffer, but the airway resistance is the same. So here our plateau pressure was 14, and here our plateau pressure is 22 centimeters of water. Why would we have the patient's plateau pressure go higher? And I want to explain why. Okay, I want to leave it simple. So let's say a patient is going into pulmonary edema. There's a lot of capillary leakage going on. I don't know if it's septic shock, ARDS, but there's a lot of capillary leakage. Fluid is accumulating in the interstitial space. And now when we do a inspiratory hold, we noticed that a couple hours ago, it was 14. Now we're measuring it and it's 22. What happened to the patient's lungs in several hours? Maybe they're going into pulmonary edema. So when you have stiff lungs, it's called restrictive. Okay, so I just want to recap what we just talked about. So we're looking at an airway graphic that shows pressure building during inspiration. And here we're seeing 4 breaths. And we notice on all 4 breaths, the respiratory therapist did an inspiratory hold. And that's why we see pressure climbing, and then the pressure stays constant for a bit before exhalation occurs. So we know this plateau is the inspiratory hold. Then we looked at the values for the peak pressure and the plateau pressure. We noticed that the peak pressure was 28 centimeters of water on this breath and 36 centimeters of water on this breath. So the peak pressure went up. We also noticed the plateau pressure was 14 here, and now it's up to 22 centimeters of water. So why would the plateau pressure increase? It could be because the patient is going into pulmonary edema, and that creates stiff lungs. So why did the plateau pressure increase? It could be that the patient is going into pulmonary edema. Edema creates stiff lungs. And that's it for this slide. Any questions? Are you guys completely lost?
So one's not gonna go up without the other.
I feel lost on this one. I don't know about everybody else.
Okay, so ask me a question.
Honestly, I wouldn't even know where to start to ask that. So yeah, I honestly don't know. I feel like I'm gonna have to review this on my own first.
Okay. Okay. And we can go through it in review also. I think when you explain it to somebody, then you can figure out the part that you don't understand versus the part that you do understand. So if you have a good study buddy, you guys can talk about it, that helps.
Yeah, I'll do that. Thank you.
I have a question.
Okay.
So the PIP, that pressure can increase if there is airway resistance, or also if the alveoli are hardened. Is that right?
Perfect, yes.
Okay, so I get that.
But you
then-
cannot say PIP. You have to say PIP or peak inspiratory pressure.
Okay, and then what about the plateau pressure? Only the hardened alveoli affect that, not the airway resistance?
Perfect, yes, you got it.
Thank you.
You're welcome. Does anybody else want to try to explain it? So the peak pressure is a combination of two things. It's a combination of the airway resistance and the stiffness of the alveoli. The plateau pressure is only the stiffness of the alveoli.
Because it's a static compliance, that's why we're only looking at the plateau pressure for the pulmonary edema.
Yes, very good. Do you wear your scrubs to lab? No. You can wear casual clothes.
Sorry, I have one more question. I think I'm getting all the terms confused. So I understand the plateau and the PIP, but then you said dynamic and static. Those static is the same thing as the PIP?
What is PIP?
The peak inspiratory pressure.
Yes.
So that would be dynamic.
Yeah, very good.
And then static is the PEEP? No, now I'm getting, is the plateau.
Yes.
Okay. It's confusing because they each have two names, I think.
I think so too.
Yeah.
All right, good job. Okay, now we're going to talk about airway resistance, and that's the difference in the peak pressure and the plateau pressure. I was telling you the further apart those two numbers are, the more airway resistance you have. So airway resistance, what does it say? Resistance refers to the pressure created by gas flowing through the endotube and conducting airways of the lungs. So it's the pressure created by the gas flowing through the endotube and airways. Resistance is affected by the condition of the conducting airways. If they are wide open, airway resistance will be low. If the airways are constricted due to bronchospasm or secretions, airway resistance will be high. Airway resistance will increase the pressure it takes to deliver volume to the lungs. So the more airway resistance you have, the higher your peak pressure. The more airway resistance you have, the higher the peak pressure. And then at the bottom, it says airway resistance affects dynamic compliance. Okay, and then applying this to the graphic that we're looking at, it says, notice that increased airway resistance causes total pressure to increase, but the plateau pressure stays the same. Airway resistance does nothing to the plateau pressure, the pressure in the alveoli. I'm going to repeat it because that's really important to know. Airway resistance has nothing to do with the plateau pressure, the pressure in the alveoli. So here we have a peak pressure of 28 centimeters of water and a plateau pressure of 15 centimeters of water. Compare that to this breath. Now we have a peak pressure of 36 centimeters of water, but the plateau pressure stayed the same. So if the plateau pressure is the same in both breaths, what caused the peak pressure to be higher?
Airway resistance.
Would,
Airway resistance, very good.
so that would be like a bronchospasm?
Yes, very good. Bronchospasm, secretions. If the patient bites down on the endotube, like when the endotube is in the patient's mouth, and we keep it to the side, probably for comfort for them. But when the tube is on the side of the mouth, it can easily get between their teeth. And if they bite down, they narrow the endotracheal tube. So the pressure will be a lot higher when they're doing that. And it's because when they bite down, they narrow the airway pretty much. So secretions, bronchospasm, biting down on the endotube, that will all cause the peak pressure to go higher. It's time for a 10-minute break. So I will pause the recording. Okay, guys, we'll keep going. I wrote a question in the chat. If a patient bites down on the endotube, will the plateau pressure increase? Brent, what do you think?
Will the plateau pressure increase? No.
Very good. Okay.
Resistance, air resistance doesn't affect plateau pressure.
Yay. Good job. Double thumbs up.
All right, thank you.
Okay, question B. If the patient bites down on the endotube, will the peak pressure increase?
That's for me
Marlon?
too.
Marlon, what do you think?
Yes.
Very good. So the peak pressure goes up, but nothing happens to the plateau pressure if the patient bites down on the endotube. Does everybody understand that?
Yes.
Okay. All right. For airway resistance, we have a formula, but before we go into the formula, name 4 causes of increased airway resistance. Karinja, can you give me a cause of airway resistance?
Retained secretions,
Okay.
incorrect ET size, and bronchospasm. Small endotracheal tube and very fast flow of air into lungs.
Oh yeah, that's right. Good job.
Thank you.
All right, well, there is a handy dandy formula to figure out airway resistance. And what you do is you're going to take the peak pressure, the peak inspiratory pressure, PIP, and you're going to subtract the plateau pressure. So peak pressure minus plateau pressure. So peak pressure is the pressure in the airways. Plateau pressure reflects the alveoli. And that's why you see this little capital P TA subscript. Trans airway pressure. So peak pressure minus the pressure in the alveoli is your trans airway pressure. Divided by flow. So you take the pressure change, divide by the flow, and you come up with your airway resistance. So these numbers will be given to you, and all you got to do is plug them into the formula. For inspiratory flow rate on the ventilator, it's always in liters per minute. However, look at these units. The units for the resistance formula is in liters per second. So how are you supposed to convert the flow rate from liters per minute to liters per second? And it tells you at the bottom in big letters, multiply the answer by 60. And when you do that, you're going to convert from liters per minute to liters per second. So if the flow rate is 30 liters a minute, you plug 30 liters a minute into the formula. After you're done dividing and you've got your answer, multiply by 60 to change it into liters per second. Because you want your answer to be in centimeters water, that's your pressure, per liter per second, and that's your flow. So pressure over flow is resistance. Does it give us a, oh, I need to give you normals. Normal airway resistance. So somebody who's not on a ventilator, breathing normally, no asthma, no nothing, their airway resistance is about 0.6 to 2.4 centimeters water per liter per second. Very small airway resistance. Then we put somebody on a ventilator. We stick in an endotracheal tube. They've probably got some other things going on. They have higher airway resistance, between 6 and 10 centimeters water per liter per second. So those are the normals. Okay, patient on the ventilator had the following values. The peak airway pressure, 58 centimeters water. Plateau pressure, 40 centimeters of water. The flow rate of gas, or the peak flow rate, is 40 liters per minute. And you need to calculate the airway resistance. So I'll give you a minute and then I'll call on somebody. Did you get it calculated? Okay. Danielle, how are you?
Hi,
Were you able to plug the numbers in?
I'm calculating it right now. Almost done.
Okay.
All right. I got 27 centimeters per water, liters per second. I don't know if you heard me.
27.0.
Yes, please.
Did everybody get that?
Can you explain how to do that, please?
Yes. Yes.
Thank you.
I can. Oops. All right, the formula for airway resistance, we have to do the pressure on the top and the flow on the bottom. For the pressure on the top, we need to know the peak airway pressure, and it's 58 centimeters of water. Where's my pen? Right? There we go. So 58 centimeters of water was the peak inspiratory pressure. Then we're going to subtract the plateau pressure because the airway resistance is the difference between those two. The plateau pressure is 40. So 58 minus 40. And then on the bottom is the flow. And the flow rate is 40 liters per minute. Are you good so far? Summer, are you okay? The peak pressure, 58 centimeters of water is here. The plateau pressure of 40 is here. So
Yeah, I got
58
it now.
minus 40, okay.
I'm following.
And then you divide by 40. So 18 over 40. Oh, can I make the letter 8? No. All right, that's an 8, guys. 18 over 40. And then you divide that on your calculator. And I don't know, you get somewhere like 19 or 18. And then you multiply by 60. And that'll change it to liters per second. Now your answers are in centimeters water per liter per second. Any questions on that? All right, a patient on a ventilator was generating pressures of 25 centimeters of water during inspiration. Now the pressures at peak inspiration are 30 centimeters of water. Is the increased pressure caused by an increase in airway resistance, or is it caused by a decrease in lung compliance? How are you supposed to know what's causing the peak pressure to be higher? So one thing you can do is you can look at the static pressures, and if they're the same, then you know it's not the alveoli. You know that there's no pulmonary edema or any changes in the alveoli. But look, they're not the same. So the static pressure was 20 and now it's 25. So what does that tell you? Airway resistance or decrease in lung compliance?
Decrease in lung compliance.
Yes, very good. All right, can you explain why you said that?
I said that because the lung compliance would decrease for things like pulmonary edema, and pulmonary edema would be if the static is increasing. If that makes sense. Is that like?
Yes, because so your static pressure is increasing. So that told you it's lung compliance that's causing the total pressure to go up.
Yeah.
Okay. Okay, so that was it for airway resistance. And now we move on to elasticity. So elasticity is the tendency of a structure to return to its original form, or the ability to recoil. So have you ever had a fresh new balloon and it's tiny, go to blow it up and your cheeks hurt because you're trying so hard to expand it? And then you let the air out, you blow it up again, so much easier. You let the air out, you blow it up again, and now the balloon is all stretchy and floppy. It doesn't really return back to that small little balloon. So when something cannot return back to its original shape, it has low elasticity. So it says here, a lung with high compliance has a decreased ability to recoil, low elastic recoil. Patients that have emphysema, they have loss of alveoli in their lungs. Their lungs are very easy to ventilate. If you put somebody with emphysema on the ventilator, very low pressures, real high compliance. The air goes in, expands the lungs, and now it's time for exhalation. And the lungs just don't go back to their original size and shape because they're so overstretched and over floppy. So they have a low ability to recoil or low elasticity. So just like that old floppy balloon that doesn't return to its original shape, the lungs are the same way. Patients that have different lung disease, like emphysema, some COPD, their lungs can inflate very easily, but the bad part is they just don't go back to their shape. They retain a lot of volume. There's a lot of air trapping in their lungs because the lungs just don't recoil back to the way they should be. So these people with high compliance, oh, I can do that right.
So elasticity has a inverse relationship to compliance.
Yes, very good. Perfect. A patient with COPD and emphysema, very stretchy lungs, high compliance, easy to push some volume into their lungs, little pressure. But do the lungs recoil? No. So we say they have low elasticity, the inability to recoil back to their original shape. So very good, Chris. You summed it up perfectly. They're opposites. A lung that is easy to ventilate, high compliance, has low elasticity. And then the next example is the last bullet. A lung with low compliance has an increased ability to recoil, has high elastic recoil. So let me explain that. Having really stiff lungs, and the ventilator has to push really hard to try to get some air into these stiff lungs. Gets the air into the stiff lungs. And then on exhalation, boom, the lungs snap back into place. Because they're so hard and it's so hard to get them to stretch that they easily go back into their normal position, I guess we'll say. Again, it's the opposite. Stiff lungs have high recoil. Hard to get the air in, but they snap right back into, I'm sure there's a better word than position. Into shape. So they recoil back into their shape very, very quickly and very easily. Okay, patient with stiff lungs has low lung compliance but high elasticity. The lungs quickly return to their original shape during exhalation. Okay, and then all these terms, I think the best thing for you guys to do is to maybe make up some index cards and write all of these definitions on index cards and then just go through them until you get familiar with them. So a time constant, let me explain a time constant. The bullet says it's the length of time required for the lungs to inflate or deflate to a certain amount or percentage of their full volume. The length of time required for the lungs to inflate. So when you're pushing a volume of air into the lungs, the amount of time it takes for the lungs to be completely filled up, it's called a time constant. Why do we care about time constants? It says this is important when setting the ventilator for the amount of time for the tidal volume to be delivered, or we keep it in mind for allowing enough time for exhalation. So the amount of time for the tidal volume to be delivered is the inspiration. So we want to make sure the inspiration is long enough to get the volume into the lungs. And we call that the time constant. There's another formula. So how many formulas have I given you so far? I gave you dynamic compliance, static compliance, airway resistance, and now time constant. So you've got 4 formulas to practice on. Time constant is taking the static compliance, multiplying by airway resistance. So when you take those two, you're going to come up with the amount of time that it takes to fill the lungs up. Calculate the time constant for a patient who is intubated on a ventilator and has normal lung values. All right, so normal lung values, it's got the static compliance, Oh, it's liters instead of mLs. See how different it looks? So instead of this saying 50 mLs per centimeter of water, it's 0.05 liters. So that's static compliance. Multiply by airway resistance. Here it's 8 centimeters water per liter per second. So these numbers are considered normal. And we come up with 0.4 seconds. So 0.4 seconds is the time it would take for a lung to fill with, not the full volume, but 63% of the volume. Bear with me, just listen along for a minute. So when we come up with the answer to that formula, we're coming up with an answer to one time constant. But in order to get all the lungs filled with air, it's not one time constant or two time constants or three time constants. It's 4 time constants to completely fill the lungs or to empty the lungs. Does it stop there? All right, so this slide puts it all together. Let's figure out how long it takes to get 98% of the full volume into the following lung. The static compliance is 30 cc's. You know that cc's and mLs mean the same thing? Have you guys heard of this already? Okay. So 30 cc's or 30 mLs per centimeter water. Converted to liters is 0.03 liters per centimeter water. The airway resistance, 10 centimeters water per liter per second. The formula for time constants is the static compliance times the airway resistance. So you plug your numbers in and you come up with the answer of 0.3 seconds. Well, 0.3 seconds tells us one time constant. But if we want to fill the lungs up completely to 98% of the full volume, we have to multiply by the number of time constants. And what did we say it was? 4 time constants. So to figure out 98% of the volume of the lungs, times 4. So it would be 0.3 seconds times 4 would give us 1.2 seconds. And is that all it tells us? No. Okay. So time constants are good for what we're going to get into next week, which is figuring out something that we monitor on the ventilator called IE ratio. Like if you're putting the air in for 1 second, you got to give it 2 seconds to come back out again. So it's kind of leading to that. But it's also looking at people that have really compliant lungs versus people that have stiff lungs. They're going to have different time constants. All right, so as far as you guys to understand the concept about time constant, break it down to 2 things. Number 1, write down a definition. And the definition is simple. Time it takes to fill the lungs. That's simple. That's a time constant. So if I'm asking you, what is a time constant? It's time it takes to fill the lungs. Okay, so the second part is you have to know the formula. All of the information will be given to you. So you just plug in the static compliance, you plug in the airway resistance. And remember, the static compliance has to be in liters, but you just multiply those 2 things and you're going to come up with the number of seconds for one time constant. And on the test, it'll say, figure out how long for 4 time constants or 98% of volume. So then you would just multiply the number you get times 4. I don't know if it asks you about 3, 2, or 1 time constant. Well, 1 is this formula. But it gives you almost all of the information. You just have to know how to plug it in and come up with a number. So 2 things you have to know about time constant: 1, the definition, and 2, the formula. Okay, so we're going to plug in some numbers and compare these two. Number 1, we're going to, oh, it's almost time to go. We'll get to it next week. So number 1, calculate the time constant for a lung that is very stiff. The static compliance is 15 cc's per centimeter of water. Airway resistance is 6 centimeters water per liter per second. So do you guys know what to do for this? You're going to multiply these 2 numbers. Brent, you know? Okay. But before you multiply these 2 numbers, what do you have to do with the cc's?
Change it to liters.
Very good. So 15 cc's is how many liters? Very good. 0.015. Oh, add 1 more 0, Brent. So Brent, type it in with the extra 0. Yes, very good. All right, so that's what we're going to use for the static compliance. Multiply by 6 because that's the airway resistance. So 0.015 times 6, and I'll call on somebody. Tell me what you got. Denzel, I don't think I've heard from you today. What did you get for 1 time constant?
I got a 0.09.
Very good. And then the units will be second. Second. All right, 0.09 seconds. All right, not long. So remember what we were talking about with really stiff lungs, how they recoil very easily. So it doesn't take much to fill it up, and it's going to recoil really quick. All right, so 0.09 seconds for 1 time constant. You guys got that written down? Gretchen, do you have that written down?
Yes,
Okay.
I started the next one.
Okay, so the time constant for a lung that's very compliant. Static compliance, 60 cc's per centimeter water. Airway resistance, the same, 6 centimeters water per liter per second. And what do you get for the answer?
.36 seconds.
Okay, very good. So 0.36 seconds for 1 time constant. Compare that and then answer the question at the bottom. Which lung would fill and empty more slowly? Which lung would fill and empty more slowly? And you're looking for the one that's going to have a longer time constant. A longer time constant tells you it's going to take longer to fill and longer to empty. Tejan, very good. The second one. So Brent, the first one is going to be a quick fill and a quick empty, because we got a short time constant for that.
Okay, so 0.09 seconds is faster than 0.36 seconds?
Yes.
Okay,
Yeah, it's less time. It's a smaller amount of time.
okay. All right, I got it. I had it backwards. All right, thank you.
You're welcome.
Would we need to know why like a more stiff lung will fill and empty faster than a less stiff lung?
Do you need to know why it fills and empties faster? As far as understanding the pathophysiology of pulmonary edema, what makes it stiff? Not at this time, no.
Okay, thank you.
You learn about it during your pathophysiology course. So I give you little bits of information to help you get through the concepts I'm teaching. But as far as knowing in depth what's happening at the alveolar level, you'll get to that in your pathophysiology.
Thank you.
Okay, so we'll stop here and we'll continue on next Thursday to finish off this packet and then start on the next packet. So I will expect the first group to be here at 12:30 to start the lab. And the second group at 3 o'clock. So I will see you guys then. Do you have any questions before I say goodbye?
Thank you, Professor.
Thank you.